Welcome back to The Curious Clinicians, a medical podcast that asks why. I'm Hannah Abrams, and I'm joined, as always, by Avi Cooper and Tony Brew. Hey, guys.
Hey, Hannah. Avi.
Good to see you both, and happy evening.
Happy evening to you too, Avi.
I've never said that before, but I just said it now.
On that note, so today's episode, I think we've got a pretty interesting one for you guys today. It's an intersection between a lot of fields: cardiology, endocrinology, pharmacology, and most importantly, hematology. So, Tony, just missing oncology. So, Tony, you recently posted a tutorial that started with a case that I really liked. You said you asked your followers to imagine that they were seeing a patient who had been recently diagnosed with heart failure and started on guideline-directed medical therapy, or GDMT. The patient's hemoglobin increased from 12 grams per deciliter before starting GDMT to 13 grams per deciliter after. And you asked people to pick A through D: empagliflozin, furosemide, sacubitril valsartan, and spironolactone. Which medication was responsible for the change? So what did you find?
Well, I should have a few caveats before we go any further. First is I'm not a huge fan of testing people on social media, but sometimes it's interesting. And here I thought the results were very interesting. But the second sort of caveat is I fully recognize that furosemide and other loop diuretics aren't typically considered a part of GDMT. But I included it in the question as one of the answers because I anticipated that some might be tempted to select it. And obviously, it's also commonly prescribed in patients who have new onset heart failure. But anyway, I was really pleased to see about 8,000 people responded to this question on Twitter, and 30% did choose furosemide. But I didn't think that was the most correct answer. I thought the winner ought to be empagliflozin. And 39% of the people who responded also chose this SGLT2 inhibitor. And that's what we're going to be talking about on today's episode. We're going to talk about why SGLT2 inhibitors lead to an increase in hemoglobin, or in some cases, they lead to outright erythrocytosis. And as a reminder for everybody, erythrocytosis is also known as polycythemia. But I think for most of this episode, we're going to be using the term erythrocytosis. So, Hannah, you've probably seen or heard about this, but maybe not. I'm not sure about you. Is this something you guys have come across? The sort of increase in hemoglobin with this class of drugs?
I always thought that it was sort of a diuretic effect. I know you're going to tell us a little bit more about how it happens. It's one of those things that's on the algorithm for what we call a JAK2 negative erythrocytosis, but I had never actually seen it in person.
What about you, Avi?
This was an unknown, I would say.
Yeah, and it was for me up until pretty recently when I saw a patient who had what ultimately was felt to be SGLT2 inhibitor associated with erythrocytosis. And this particular patient had a hemoglobin that had risen above the upper limit of normal. And I didn't know why. And I was caring for them in the hospital, and they were hospitalized for something totally unrelated to their hemoglobin. So we sent a few tests, but they didn't come back while the patient was in the hospital. And so we sent them home with a planned follow-up with hematology. And a couple of months later, I was doing kind of like a routine review of cases of patients I had cared for that had unresolved questions. And this was one of those cases. And when I looked at the hematology follow-up, the really brilliant fellow wrote in their note that the patient's empagliflozin was the likely culprit for the increased hemoglobin. And I hadn't heard about this before this. And this was just a few months ago. And I, as you might imagine, wanted to learn a little bit more about, how often does this happen, how severe, and ultimately what's the mechanism.
Yeah. And so maybe it'd be helpful to start first talking about a brief reminder about SGLT2 inhibitors, one of the wonder drugs of the past 10 years, a frequent Neff Madness. I think there was actually a Neff Madness team called the Flozinators because they were so passionate about the life prolonging and symptom reducing properties of this class of drugs. So, as the name suggests, or the name stands for, they inhibit the sodium glucose cotransporter 2, thereby blocking the reabsorption of glucose into the kidneys. So, they were originally studied for diabetes. That's how I learned about it in medical school as an agent for glycemic control. And then just during my residency, they really were shown to have very broad benefits for both cardiovascular and renal outcomes in a bunch of different situations.
Yeah, it almost feels like every few months there's some new benefit that's found. It's sort of like latter day statins a little bit. So Tony, when were SGLT2 inhibitors? When were they first observed to have this effect on hemoglobin that astute hematology fellow picked up on for your patient?
It, I was pretty amazed to find that this effect on hemoglobin hematocrit has been noted since the very first randomized control trial of this class of drugs, and that was dapagliflozin. And that study, that first RCT, was published in 2010. It was a multi-center, double-blind, placebo-controlled trial, and included more than 500 adults with type 2 diabetes. And the study found improved glycemic control with dapagliflozin, and that was the primary outcome. But the authors also noted a small but dose-dependent increase in both the mean blood urea nitrogen, or BUN, and a dose-dependent increase in hematocrit in the arm that was taking dapagliflozin, and they didn't see that in the arm that was taking placebo. Now, they don't report the hemoglobin values, but I think it's a reasonable assumption to make that those values increased as well. They only reported the hematocrit.
So, thinking about potential mechanism for this effect, Hannah, you had mentioned this sort of maybe like a hemoconcentration effect. That certainly would make sense to me. If these drugs are blocking glucose reabsorption in the kidney, they should have a diuretic-like effect. Um, is that where that rise in hematocrit that they saw comes from?
Yeah, that's certainly what the authors of this early RCT thought. And they wrote in the discussion for that paper that the increase was consistent with a glucose induced osmotic diuresis. And they felt that the increase in BUN actually supported that mechanism, which is why, in the paper, they include those two findings together. And other early investigators who looked at this class of drugs assumed this to be the mechanism as well. But as more and more data accumulated, it became clear that a decrease in plasma volume alone really couldn't explain the increase in hemoglobin and hematocrit. And this is actually supported by observations that diuretics like furosemide, they aren't typically associated with a persistent rise in hemoglobin and hematocrit. And you certainly are seeing that in some patients who are on SGLT2 inhibitors.
All right, so we now know that SGLT2 inhibitors increase hemoglobin or are associated with an increase in hemoglobin and hematocrit and BUN. But that you're totally right, Tony. It doesn't make sense. We give diuretics all the time without an increase or necessarily in hemoglobin in the same way. So, how much of an increase in hemoglobin and hematocrit are we talking about here? Is this something small?
Yeah, so in the 2010 RCT that I've referenced a couple times, the increase was between 1 and 1.7% in hemoglobin, in hematocrit, and that depended on the dose that was used. So, 1% for the lower dose, 1.7 for the higher dose. And a 2021 meta-analysis looked at 78 studies. So there's been a lot of studies of this class of drug. And they found an average increase of 2.3% in hematocrit and zero 0.6 grams per deciliter in hemoglobin. And these may not seem like huge increases, but they're just averages. And there are certainly cases where the hemoglobin has risen more than 4 grams per deciliter after starting one of these drugs. So, the average may be 0.6 for hemoglobin, but you can see greater increases than that. In my patients, hemoglobin rose more than 2 grams per deciliter.
Especially with the number of patients that are now on these drugs. I mean, the
Right.
scale could be really big. And I guess one thing that you wonder about too, obviously, you have to approach each patient differently, but um, you wonder if the timing is clear and say maybe
Right.
the drug is held in the the erythrocytosis resolves, maybe you wonder if the perhaps times we might be able to avoid sort of a invasive, expensive workup for erythrocytosis. The things that I think about, like certainly like in the pulmonary side, we think about chronic hypoxemia. That's a cult, like sleep apnea. So we're working up for that, or
Right.
sending JAK2 mutations, bone marrow biopsies that Hannah does. And so you wonder if we're knowing about this, maybe some patients can be spared some of that. But so if it
Right.
isn't hemoconcentration, Tony, like what is the cause of these increases in hemoglobin?
Yeah, so some of the earliest studies of this class of drug also noted an increase in red blood cell mass. And alongside that, they also found increases in erythropoietin, or EPO. And so this suggests that SGLT2 inhibitors seem to promote the generation of new red blood cells via an increase in EPO. And subsequent data has confirmed this finding, and multiple studies have shown this. And one meta analysis suggested that the mean increase in EPO is about 2.6 international units per liter. And I don't know if that's a lot, but it certainly seems to be enough to lead to an increase in hemoglobin.
Yeah, so this is really interesting to me. One, it's not at all what I thought,
Shocking.
because I was totally on the frame of like, oh, it's just a diuretic hemo concentration effect. And two, wow, another disease that SGLT2 inhibitors can fix, which is low EPO states. Just kidding. But which, we think about chronic kidney disease and its effect. But I mean, it seems like the researchers also kind of weren't really anticipating this. This wasn't in the initial explanation in the trial.
Right, right.
What has anyone dug into this? What is the cause?
Yeah, there's actually been quite a few attempts to find a clear mechanism, and I think we're getting there, but I'm not certain that it's been fully elucidated yet. And actually, Milton Packer has been kind of a lead person writing about this topic. And for the audience, Milton Packer is the father of the neurohormonal hypothesis in heart failure. So he's a very accomplished researcher. And I found somewhere in the order of 4 hypotheses that have been offered. There are probably more, and we're not going to go over all of them on the show, but we'll link to a great 2023 review by Milton Packer where he goes over each of these 4 hypotheses. Um, I do want to ask you guys a question though before we get into the one that he favors and the one that I think that's most interesting. And the question I want to ask you guys is a little bit of a trap, so recognize that.
It's like Admiral Akbar alert.
So exactly. God, yeah, we definitely can have a meme for this. So what organ would you guys guess is responsible for the augmentation of EPO? What organ is making the EPO?
I mean, the multiple choice answer would be
I know, Tony, you're full of quizzes.
kidneys,
I know, right?
But I'm guessing if this is a trap, it's not the kidney.
Well, exactly, right. If I was asking this question on rounds, I think I would be really bemoaned by the team because, like, it's got to be the kidneys, right? And that's certainly, I think that may be the case. By the way, I don't know that it's again fully settled. But because the kidneys are the usual site of EPO production, it is a fair assumption that would be the site of EPO production after the administration of these drugs. But a non-renal source is suggested by the observation that patients with chronic kidney disease are still able to augment EPO production after starting an SGLT2 inhibitor. And Hannah, you just kind of alluded to this a moment ago, but if the anemia in CKD is at least in part related to a reduction in EPO production, they sort of can't keep up, the kidneys can't keep up. It points to another source of EPO if suddenly the EPO is able to go up in this patient population.
Okay, well, if it's not the kidney, then like where the heck is it coming from?
Yeah,
There's only 30 other organs to choose from.
Exactly. Well, it's funny. The if you ask on rounds like what makes X, often the answer is the liver, and I think in this case that may end up being the answer. And this was actually one of the really surprising things I learned in researching this topic, or maybe I learned it in medical school when I learned about embryology and I totally forgot it. But human development. But it turns out that in utero, the liver is the main site of EPO production, and after birth, the kidneys sort of take over and become the main source. And so the question then becomes, all right, if in utero the liver is able to make EPO and then it kind of stops doing it, do we ever see the liver's EPO producing ability come back after birth? And it appears that we do. There is some data suggesting that the liver's production of EPO can increase in patients with end-stage renal disease. And this is the exact population that has trouble making EPO in the kidney in the first place. There was one study that included patients with end-stage renal disease, and about 50% or so had evidence of liver EPO production. And in some cases, the EPO level rose back into the reference range. Now, this wasn't enough to correct the anemia because there are still other mechanisms at play, but it suggests that the liver is still kind of waiting in the wings. And Milton Packer has suggested that the SGLT2 inhibitors, they actually upregulate signaling pathways to promote transcription of the EPO gene in the liver. So that's his favored hypothesis. And so ultimately, it could be that this class of drugs is able to turn on the quiescent liver's function of making EPO. This is not proved. It's still a hypothesis, but I find it really tempting.
Tony, did you see any link with like liver disease and whether or not these folks get? Because you would expect if it's a liver source of EPO, if you have chronic liver disease,
what a great question.
Maybe you're not going to get erythrocytosis. But
yeah, that's a great question. Like, is the ability to augment and have this finding blunted in patients with cirrhosis or end-stage liver disease? I didn't see that, but it's a fascinating question, but I didn't specifically look for it. There may be something out there, so I'm going to look after the episode's over.
It's a super interesting hypothesis. I mean, what do we know? Do we know anything about these signaling pathways that he's invoking that prompt increased gene transcription or promotion of EPO production in the liver?
Yeah, I've said this a few times, and I'll just sort of reiterate it because it could be that in a year this episode is outdated. But I don't think it's been fully worked out, and this hypothesis still needs to be confirmed. So I'm not going to go into like too much of the weeds, but I'll sort of give a little bit of a flavor for how this might look mechanistically. So Hannah, as you mentioned earlier, these agents, they induce glycosuria, and that actually leads to a state of starvation mimicry. And this causes the cells of the body to activate numerous master switches that prioritize cellular health and survival over cellular growth and replication. And one of these master switches is called sirtuin-1 or SIRT1. And I feel like we've mentioned this on one of the episodes in the past. And then through various additional downstream mediators, ultimately you get to HIF2 alpha and HNF4. And when these are augmented, they in turn promote the erythropoietin gene to be transcribed, potentially in the liver. And once the EPO gene is turned on, you get more RBCs and you get more hemoglobin. So I think there's a lot of arrows and a lot of pathways that are involved. But it's ultimately EPO is increased.
So, I mean, it sounds like the researchers are pretty confident that SGLT2 inhibitors can lead to a rise in EPO. Where exactly the arrows point in this kind of complex array of intermediates seems maybe to be determined. But that makes sense. And you're right, Tony. We see, for example, I think Chuvash polycythemia is a form of polycythemia where that HIF1, I think HIF1 or 2 alpha is increased. One of these hypoxia inducing factors is increased. Yeah. And you can get polycythemia from that. That's JAK negative. That's also sort of like on the list. Right. So it makes sense. And it's a super interesting hypothesis that totally kind of debunks how I had thought about SGLT2 inhibitors before.
I also
What else can they do?
Well,
Yeah,
I also I like
exactly.
the sort of these epiphenomena, right? That like we're still sort
Right.
of sorting out and we don't fully understand. But really very interesting. Tony, is there anything else that you learned about this topic that you wanted to share before we wrap up?
Well, to Hannah's aside, that like, what else is it that these drugs do? When I was researching this, um, iron and hemoglobin are obviously intimately related. And so a lot of the articles that talk about the effect on hemoglobin EPO levels also talk about iron. And because SGLT2 inhibitors dampen the inflammatory milieu, they actually lead to a decrease in both hepcidin and ferritin in patients who are prescribed them. And this mitigates some of the iron restriction that's seen in CKD and heart failure, which is like another amazing thing.
Interesting. So, if a patient's ferritin decreases after starting an SGLT2 inhibitor, maybe it was in like a mid-normal range. Are they iron deficient from sort of pumping out red blood cells? That
Yeah, this is another thing that I don't think has been settled, though most of the articles that I came across argued that the decrease in ferritin is actually a good thing and may be an indicator of increased cytosolic iron. And it's really the cytosolic iron that's responsible for the synthesis of heme. It's the kind of like parameter that we're most interested in. So a lower serum ferritin paired with a higher cytosolic iron would be a good outcome. But unfortunately, we don't easily or can't easily measure cytosolic iron, so it's kind of hard to confirm that that's actually what's happening. So as a result, there's some uncertainty as to what we ought to do in this situation. Like, should we give these patients IV iron or PO iron to sort of mitigate the decrease in ferritin? More to
We
come.
need a point of care cytosolic iron test.
Yeah,
you know what you
exactly.
need.
Someone get on that.
You talked the patient back into a bone marrow biopsy.
Exactly.
You know what you
The
need?
best way to look
You
at
know
your
what you
iron
need?
stores is sort of the gold standard.
Yeah. Well, I'd love to be able
no.
to send a hepcidin level. I still have never sent that.
Is that orderable? Do we have
somewhere
a hepcidin assay?
there's got to be someone who does
Someone is doing it.
Yeah.
Someone is doing it. Anything else? Any take-home points for us, Tony?
No, yeah, just some take-home points. That's all I got. And I got 3. So the first is that SGLT2 inhibitors have been shown to cause an increase in hemoglobin. 2, this is likely due to an augmentation of EPO production, possibly in the liver. More to come on that. And 3, SGLT2 inhibitors also lead to reductions in both hepcidin and ferritin.
All right. Well, that wraps up another episode of The Curious Clinicians. So thank you, as always, for joining us. Claire Morgan of notearly.com is our audio editor, and Giancarlo Bonomo is a producer for the show. You can join our mailing list at curiousclinicians.com to stay up to date on episode releases and have detailed notes delivered directly to your inbox. You can subscribe to our Substack at thecuriousclinicians.substack.com, and you can watch a video of this episode on our YouTube channel, The Curious Clinicians Podcast. So that's a new one. Physicians and other healthcare professionals can earn CME and MOC credits from VCU Health just for listening to this episode. For more information, visit ce.vcuhealth.org/curiousclinicians. And as always, the information contained in this episode is for educational and entertainment purposes only and does not constitute medical advice. Until next time, we've been the Curious Clinicians.